Welcome to DC2B Revolution. I'm your host, Noah Volz, and this is where I'm helping chiropractic students think big in order to live large. Today, I'm here with Dr. Benjamin Fergus. He's the clinical director at Cornerstone Health in Evanston, Illinois, where he specializes in chronic and complex conditions, neurological injuries, and elite athletic performance. He's the founder of GRIP Approach Seminars and lectures internationally on global rehabilitation and injury prevention. That's the acronym GRIP, and integrative medical practices. Dr. Benjamin Fergus, thanks so much for being here.
Thank you for having me.
Yeah, my pleasure. So, before we really get into GRIP and everything that you're doing, I wonder if you could... What's that?
Oh, I think I'm getting a lag on the video. You're a bit frozen there, but thank you for having me.
Oh yeah, my pleasure. So I guess where I wanted to start with you is your origin story. Sure. It feels to me like you're really advancing the profession and moving chiropractic forward with everything that you're creating. Can you give us kind of the milestones along that path that led you in that direction?
Sure. Great question. Well, I think going through chiropractic school when I was a student, I was interested in absorbing as many different avenues for treatment and care and diagnosis as I could. And one thing that was very motivating for me was finding really tricky cases, case presentations in student clinic or that professors had discussed, and really looking at things that didn't have a very clear, definable solution. And I thought those were the most interesting cases to dive deep in and say, if we don't have a really good treatment parameter set up for evaluating, classifying, and forming a treatment plan for these conditions, is there any avenue we can look at in the research to develop some form of a framework to have a positive patient interaction? So that kind of let me dive into a couple different areas of study. And one that really stuck with me when I read through some of their papers was dynamic neuromuscular stabilization. That's out of the Prague School of Rehab, Motel Hospital in the Czech Republic. And I started to get into their work initially and see that some of the founders of that school of rehabilitation, Professor Carol Levitt and Vladimir Yonder, and currently Professor Kolaj, they and their work has been referenced and cited in a lot of the other books I was going through as well. I think that was a really big factor, is finding that body of work and diving really deep into the study from that perspective.
Yeah, brilliant. Thank you for sharing that. I imagine most students haven't heard of that, but I know, we get taught upper cross syndrome, so a lot of us haven't heard of Yonder.
Or Yonder. Right.
Yeah, but that's about the extent of it. So, as you kind of started to develop that skill set, what was the next stage in your evolution, so to speak, as you kind of found a foundation that you could build on?
Sure.
Where did you go from there?
Well, what I'm trying to put together with GRIP for quite a while started with hosting classes in my area of other well-established programs like dynamic neuromuscular stabilization. I've hosted a Yonder approach course that was taught by a friend and colleague, physical therapist Robert Lardner, who's absolutely brilliant. And I started to piece together these other methods as well, neurodynamics and Mosley and Butler's pain science, and looking at things not at necessarily how they were all different, but where each pathway sort of said the same thing in their own unique language. And those areas of convergence between what we have in the chiropractic literature, what we have in pain science and in rehab, where they all converge and are trying to accomplish the same goal or say the same thing, seemed like very powerful areas for me. So I spent a lot of my time looking at those and saying, well, if we have Yonder's upper cross syndrome and we have this presentation in the connective tissue, and we have thoracic outlet syndrome or T4 syndrome from more of the chiropractic perspective, how can we look at all these avenues of diagnosis and assessment and refine those processes to get a better idea of, do we go down the traditional chiropractic route of joint mobilization? Do we go through a postural program or a soft tissue program, or do we explain the framework around this clinical presentation more clearly and effectively to the patient? And that's kind of step two, is take the available literature that we all have access to, see where things are converging and saying the same thing in their own language, and then build a framework around that to guide clinical practice.
Yeah, brilliant. So it sounds like you, in a way, you almost synthesized all of these seemingly divergent different systems, with the pain science, with the chiropractic, and then brought those together and started to bring that into your clinical practice.
Yeah,
so,
absolutely.
Yeah. So can you what does your clinical practice look like? I mean, how do you leverage the research that you're coming across in a way to to really bring that into a clinical setting? Because that to me, it seems like a very remarkable skill.
Well, thank you. Well, my clinical practice is a little unique in comparison to a lot of the chiropractic offices I've been in. Some of the unique things is our main focus is chronic and unresolved, or chronic and complex cases. So what that may mean is somebody who is presenting in our office has typically been to a few different medical doctors and potentially chiropractors and physical therapists, and they've tried a lot of different therapies that may be a little bit separate, or sometimes they repeat a therapy with a different practitioner. And for whatever reason, it wasn't effective for them. They still have the presentation they started with, or some level of it, and they're looking for a resolution. And that's where we fit in our local community, at least, is providing a detailed second opinion that is outside of the norms of what they've seen up to that point. And that gives us a really good opportunity to say, here's what the literature says today. This is new. I read this last month, or I was at a conference that presented this 1 year ago, or this is where trends are moving. And I present that directly to the patient. I say, I know you've had some lack of success with treatment methods in the past, but since that time where you're trying to solve this, we've learned a lot more interesting things about the way the body works, and we'd like to access that a little bit for your treatment. And patients are really excited about it. They're really kind of enthused by having a potential new option to resolve whatever's going on. So as far as integrating the literature into practice, it happens on a one-to-one basis with the patients I'm with, but also on the back end, when we meet with our team of doctors, we're always discussing a case of, here's what the presentation is, and maybe our traditional ways of treating it. This is what didn't work for the patient, and what are some reasons why it didn't work for the patient, and where can we access some new information to provide some hope and some possibility for improvement for this person.
Wow, that sounds marvelous. I mean, I know so many patients who feel like they've exhausted all of their options. Sure. And for you to create something where they actually can get the relief they're looking for, or at least explore a different avenue that they haven't tried before. What would you recommend for somebody in my shoes? I'm in school. I'd love to work with chronic and complex cases, but at this point, my knowledge base does not seem big enough. I don't even know where to look in terms of the research to have the resources to figure out what kind of clinical applications I would utilize. If you had to start at square one, knowing what you know now, what would you do kind of for somebody in my shoes?
Yeah, that's a great question. So I'll just kind of repeat my journey a little bit into chronic and complex presentations and what I utilize to study up on it. First of all, what every chiropractor in your position going through school and preparing for clinic should keep in mind is probably the most important part of what you do is establishing a really secure working environment with the patient in front of you. What's right for my patient today might not be right in any way for my patient tomorrow and across the offices. So being in tune with the needs of your patient and what's worked for them in the past, what they have a fear about, what they're really happy and comfortable with. That's probably the number one thing you can start to think about, is just that patient interaction for these complex patients. They're often seeing you on one of the worst days of their life. And that may be hard for us to, come from a pretty good day for ourselves and meet somebody where they're at in a pretty bad day. So patient interaction is, number one, very important. Beyond that, in my area, a really good source for me has been working with the counselors that treat patients with PTSD and chronic pain and other psychosomatic type conditions, and saying, hey, I want to know what happens in your clinic. When these patients come in and they have issues at home, with their job, with their family, or other diagnosed conditions and pain, how do these two different methods work together? How do you see a physical component of treatment being effective for your patients that are seeking you for more psychotherapy methods? And that built a very good relationship of learning with the local mental health professionals. After that, PubMed is absolutely your friend. It's such a resource that's underutilized, but if you get on PubMed and use the keyword searches, just identifying different categories of pain and different categories of muscle or nerve dysfunction, and really looking at them and saying, okay, if I have this presentation of motor weakness, the sensory system is okay, and they don't have a very good relationship with pain from a psychological perspective, what does that picture present with? What are the different categories that feed in to a patient walking in my door that way? And then you can start to divide out those presentations into something you can take action on. So to kind of summarize, one, establish a really good working relationship with them. Two, get in touch with some mental health professionals. Talk about the psychological component of not being able to walk or not being able to sleep due to pain or dysfunction. And thirdly, access the literature on PubMed. It's a really good resource.
Yeah, brilliant. Thank you for kind of walking through those steps one by one so that, students can really utilize that. I don't know how every other school is, but I know at my school, the research seems very underutilized.
Right.
In terms
I think it's like that in most schools. There's reference to the literature, but it's sort of one of those, like, you should be in an evidence-based practice. There is evidence for some things. There's not evidence for others. But for many people, it's not until they get into active practice and say, what is presenting in my office and why is it not responding? What are they doing in Japan? What are they doing in Denmark and in South Africa? And say, okay, globally around the world, people have these issues. We can pool resources and start to find some solutions.
Yeah, and I think that's really what all of us as students want, and chiropractors too, is finding solutions for the people who come up into our door. And I loved how you frame that in terms of the first step is really building rapport and trust with the person you're working with, because that's the first stepping stone towards really finding a solution for them. I wanted to kind of jump back to grip a little bit and talk about that approach that you've developed, and talk a little bit about what makes it unique. When I was looking at the website, it reminded me a lot of like SFMA and ART and other things. So I'm wondering, how you kind of present it and what it's similar to.
Yeah, well, thank you for the question. I think anything that's developed in healthcare is going to have some similarities with some other methods that are available. So I'll try to highlight some areas where what we're doing is a little bit unique, and some areas where we've drawn heavily from what's currently available in the literature and other methods. So bottom line, GRIP is a movement assessment or a motor control assessment that looks at the body in joint regions in a single plane of motion at a time. So to break that down, if I'm performing an evaluation on an individual, I want to ask, does the brain, peripheral nervous system, muscle, joint, etc., work together in a unit to create a specific movement in a single plane of motion. And we'd evaluate that at the neck, the thoracic spine, at the elbow, at the wrist, etc., so that we really break down the body into very clearly definable regions and very clearly definable actions. To take the assessment portion a little bit further, what the assessment is doing is sort of like palpating the brain's ability to control the body. So as chiropractors, we're accustomed to palpating a joint in 3 planes of motion and assess its function. Does it have adequate movement in 3 planes of motion? Is it excessive? Does it palpate well, essentially? And then we have some really good corrections for that. In grip, we're essentially asking the central nervous system, can you move this joint complex in 3 planes of motion? And if you're stuck in 1 plane, how does your body compensate for that? Where do you steal movement or steal muscle activity or endurance, etc., in order to provide left lateral flexion of the neck? And the assessment looks at it in that way. We establish a couple neutral zones that we always want to have a pretty good sense of control over, and then we generate movement away from those neutral zones. So grip starts as an assessment, and when we go through a patient assessment, we have a really clear, definable way of saying, this person's nervous system is having a hard time generating these 5 movements. These 3 are clinically the most important. And then that test becomes actionable, and that it leads to some strategies for correcting that loss of motion that have been pretty reliable over the years, clinically, empirical studies, as well as referencing the current literature available. So there's a treatment arm and an assessment arm.
Beautiful. Yeah. Thanks for kind of walking through that. I mean, that sounds great to me. When are you coming to California?
Oh, that would be great. We're mostly presenting in the Midwest this year, but we are planning some courses out on the West Coast next year. We present a performance portion of the course as well here in the Midwest and in Asia. That's presented in Japan and Taiwan and in Korea to specifically work with athletic trainers and strength coaches and how to evaluate their athletes for potentially injury prevention and certainly to create some performance. But California, that'd be a dream. We'll set something up.
All right, good. So, we've talked a lot about, what you do clinically. We've talked about this training that you've developed. I wonder if you could just touch on your practice model or your business model. You're the director of Cornerstone Health. And so, what responsibilities do you have as a director outside of your clinical responsibilities? And how have you set up the model of your practice to really support these complex conditions that you treat?
Yeah, that's a really good question. I think that question would assume that maybe other students in your position would be interested in treating complex and chronic conditions. And some are, and honestly, some aren't, and that's okay as well. There's a lot of clinics that focus on acute, subacute presentations and do really well from a professional standpoint, but it's not our focus. In fact, when a pretty straightforward, simple case comes in, often we will refer and work with others in the area to handle a couple of the more straightforward cases. So assuming that somebody wants to get into treating complex and chronic cases, the way we set up is first to be a quality resource of diagnosis. So when somebody comes in, we don't make promises of effectiveness or of one treatment method working. Essentially, our promise to our patients is that nobody's going to look deeper at this than what we do. And so we spend a lot of time studying diagnostic methods and working with other diagnostic physicians in our area to really hone down the diagnostic procedures and give a good answer to a lot of patients that have been searching for that answer and not getting it. So it starts with that simple promise. We're going to look deeper. We're going to do a better evaluation. We're going to give you as much information as we can gain from it. And then that pretty seamlessly leads into the types of treatments that are available. So as far as the setup of the practice, when I started, it was solo all the way. It was me in a clinic with 2 rooms, a rehab room, and a front desk. I was answering my phones, scheduling my patients, doing the exams, the paperwork, the whole works from start to finish. And I think starting, that actually gave me a good opportunity to spend the time to create really good rapport with my patients, which I found to be, again, a very effective part of treating complex and chronic conditions, is establishing that relationship. But as we grew and our practice picked up, I noticed a few deficiencies in me working as a solo practitioner that we needed to fill. One was that patients that called in would say, I've got condition A in my shoulder, I've got this neurological condition in my spine, I've got this skin condition and this hair condition, and I've heard you can handle it all. And we're like, well, great. I'm glad somebody gave you a good referral. But I was much more effective in treating the neurological spine case and the shoulder than I was if I tried to do that while also looking at skin, hair, and diet. So although we have some training in that, and that's part of the whole organism, it's more effective for clarity and performance of the treatment techniques if you involve other professionals in that. So what we did is, for each practitioner, and we have 3 currently, we tried to define a few areas of really strong points of effective treatment for those individuals. And although we can talk about all the cases together, when somebody calls in with a certain condition, we wanted to really clearly say, you're going to be seeing Dr. Ryan. He leads this type of care. He'll be consulting with other physicians to find the right diagnosis for you. And we'd really separate it in that way. And so we've grown from a solo practitioner up to 3 doctors that work in the system right now. And we also started to integrate some strength training and some group training, as the literature really supports that as an effective therapy currently.
Yeah, I mean, that sounds great. I love this multidisciplinary approach that you've developed. And yeah, and I love this idea of, it's almost like you have a pod, you know, and you get to, you have one person leading care, but then you have all of these other resources that you can utilize within the clinic to ensure that everybody gets the best care. And I mean, that's just a really nice model. I haven't heard that before. So thank you for sharing that.
Thank you. I think something that actually you hit on a good point for students that are getting ready to graduate, and that whether you work in a group practice or a solo practice or as a very busy associate, I think what I see from a lot of colleagues is one of the most important factors for success is having a really good network of people to discuss tricky cases with. For us, we do most of that in-house, but when I was working as a solo practitioner, I would easily pick up the phone call and talk to the best professionals in my network. So I think that's really good, whether it's in-house or with others. When you're first graduating, establish a really good group of people that you can conference with on cases.
Thank you. Yeah, I mean, it almost is like school, you know, when we have these mentor docs and they're kind of walking us through things. And so I know most students in my position want to go into associate position because they want that to be kind of built in to the process. I love this idea that it's not necessary that you go in a position where you're an associate. You can find those mentors outside of an associate position. Because just like doing this channel, chiropractors are so generous with their time and so willing to help young chiropractors succeed and, you know, make their mark, or, you know, kind of create their authentic practice. So that's really, really special, I feel like. The last question I have for you is, you know, where can people learn more about you, the clinic, GRIP? You know, you're doing so much, and I know a lot of people are going to be really curious about the training that you provide and all of the other things that you're doing. So what's the best place to find you?
Yeah, so most of my educational programs can be found on our education website, which is gripapproach.com. grip.com. And GRIP, like you mentioned earlier, stands for Global Rehab and Injury Prevention. So we have both our clinical courses, our performance courses, and our guest courses that come in to challenge and strengthen what we do. So gripapproach.com. The social media sites are all about the same. So Grip Approach is on Facebook, on Instagram, and on Twitter. And out of all of those, Facebook and Instagram were probably the most active on. As far as my clinic, it's cornerstoneclinics.com. We're in Evanston, Illinois, and we're also on social media fairly lightly as well.
Perfect. Yeah, thank you so much for sharing that information. So this has been a production of DC to Be Revolution, helping chiropractic students think big in order to live large. If you like this video, please subscribe to the channel, leave some comments below. And Dr. Ben Fergus, thanks so much for being here.
Yeah, thanks for having me. Good luck with your program.